Hey guys, welcome back to Conceptual Medicine Case of the Week series, and this is episode 3, and we're going to have an interesting case ahead. Here's a 29-year-old woman presenting with 6-year history of progressive facial changes. Her BP is slightly elevated, 145.90 millimeters of mercury, and she has a visible goiter that is nothing but thyromegaly. Her picture is shown, what you're seeing in the picture. Her facial features appear coarse though, frontal bossing, prognathism, large nose, large lips, prominent zygomatic bones, and there is a lot of soft tissue swelling as well. This is a typical case of acromegaly. If you take skull X-ray, you will see enlarged sinuses. You might see laryngeal hypertrophy as well. You will see pharyngeal soft tissue hypertrophy and macroglossia. Because of that, these patients can experience very severe obstructive sleep apneas. And of course, the dental sockets may appear bigger in X-rays. Because of that, they might get a lot of dental malocclusions in the future. And these patients also tend to develop a lot of organomegalies. Of course, cardiomegaly is an important risk factor for future cardiomyopathy, but we don't know the exact true impact of thyromegaly and adrenomegaly that occurs very commonly in these patients. So what is the most likely diagnosis? Without a doubt, this is a case of acromegaly, at least clinically as of now. And what is the first test that they're going to perform? It's going to be serum IGF-1 levels. This is going to act as a screening test, very high sensitivity. If the serum IGF-1 levels are normal, you're going to kind of exclude the diagnosis of growth hormone excess. But if it's elevated, it doesn't really confirm. It's not very specific, so you need to confirm with one important test. So what test is going to confirm the diagnosis? Because in this case, IGF-1 levels were elevated. It's going to be the 75-gram oral glucose tolerance test. So what you're going to do, you're going to load the patient with a 75-gram oral glucose, and after 2 hours, you're going to check for growth hormone levels. The growth hormone levels are suppressed, which means if it becomes undetectable by any standard assay, you can say it kind of rules out growth hormone excess because this is a normal response. And in case if the growth hormone levels are detectable by any standard assays that you perform, it kind of confirms growth hormone excess, and you're dealing with a case of acromegaly for sure. So what do you mean by the term detectable and what do you mean by the term undetectable though? So depending on the assay type, it could be less than 0.4 to 1 nanogram per ml, depending on the assay type. So if you're using traditional older assays, the cutoff will be 1 nanogram per ml. If you're using newer high sensitivity assays, the cutoff will be less than 0.3 to 0.4 because the newer assays are very sensitive. The lower limit of detection will be 0.3 to 0.4, but in older assays, the lower limit of detection will be 1 nanogram per ml. But nevertheless, whatever the assay you use, it should be less than the lower limit of detection. So that's what you mean by undetectable range. So what do you mean by detectable? It's going to be more than 0.4 to 1 nanogram per ml, depending on the assay type in your hospital. So now we know how to screen and confirm growth hormone excess and acromegaly. Now let us have a look at some theory. As I said, if you're having clinical signs of acromegaly, the next step is to do serum IGF-1. If it's normal, it kind of rules out acromegaly and growth hormone excess. If it's elevated, you have to confirm with OGTT. You give a 75-gram oral glucose, and after that, you're going to go for growth hormone measurements. If the 2-hour 75-gram OGTT shows adequately suppressed growth hormone levels, again, you can exclude acromegaly. If it's not, you can confirm acromegaly, that's growth hormone excess. Now, next step is to localize. For that, we are going to perform a pituitary MRI. In pituitary MRI, if you're going to see a visible mass, then your diagnosis of growth hormone secreting pituitary adenoma is confirmed, which is also called as somatostatin adenoma. And this is the most common cause of acromegaly in the world right now. More than 90 to 95% of the case of acromegaly will be due to growth hormone secreting pituitary adenoma. But very, very rarely, it might be due to ectopic growth hormone or growth hormone releasing hormone secretion by tumors like pancreatic neuroendocrine neoplasms or medullary thyroid cancers or even small cell lung cancer. So in case the pituitary MRI is normal, but you have a clear biochemical evidence of growth hormone excess, the next step is to screen for extra pituitary source. In that case, your FDG-PET will be an ideal investigation, which is going to give you the answer. So coming to the management. So first thing, in case if the patient is having a growth hormone secreting pituitary adenoma, you have to see whether the patient is a surgical candidate or not. In case if the patient is a surgical candidate, where to go for surgery. Surgery that you're talking about is transfemoral surgery, right? So in case the patient is not a surgical candidate, then you can opt for medical therapy. So what are the indications for medical therapy? Number 1, as a bridge to surgery. Number 2, if the patient is unfit for surgery. Number 3, if the surgery fails. The post-operative IGF-1 levels or probably 75-gram OGTT levels are still like not satisfactory, then probably you can go for medical therapy to control growth hormone levels. So what do you mean by SRL? These are somatostatin receptor ligands, or simply called as SSTR agonists or somatostatin receptor agonists. These are going to be the first line of medical therapy. And the first line SRLs that we're going to use is going to be either octreotide or probably lanreotide, which is available in depot formulation. So in case if the first line SRLs fail, what are the options you have? So either you can increase the dose of first line SRLs can try the maximum possible dose, or probably you can shift to a different SRL. In this case, we are going to think in terms of pasireotide, which is a kind of selective SSTR5 agonist. So that's going to be more effective than the traditional octreotide and lanreotide. Or probably you can shift to a new drug, new class of drug altogether, that is growth hormone receptor antagonist, like for example, pegvisomant. But trust me, if you give pegvisomant, your growth hormone levels can even increase. The reason for that is once you block the growth hormone receptor, you're going to create a kind of resistance to growth hormone. So your growth hormone levels might increase with pegvisomant, but nevertheless, you get a good effect with regards to soft tissue swelling. It's going to reduce after giving pegvisomant. Or you can try some combination therapy. So what combination? You can try combination of SRL with pegvisomant, like either octreotide with pegvisomant or even pasireotide with pegvisomant. So combination number 1 is an SRL with pegvisomant, or you can try another combination in certain selected subset of patients, especially those patients who are having like prolactin excess. So 25% of acromegaly cases will be also having prolactin co-secretion. And in those cases, especially high-dose cabergoline might work. You can try dopamine receptor agonist as well. High-dose cabergoline, in the sense, the usual dose of cabergoline will be 0.25 to 0.5 milligram once or twice a week. That's what we use in a case of prolactinoma, but here we can use 2 to 3 milligram per week or even 0.5 milligram daily. So that is high-dose cabergoline. In some cases, it might work. So these are the other options that we have in patients with resistant growth hormone excess. Coming back to our case, pituitary MRI shows a 1.5 centimeter intracellular macroadenoma. Patient undergoes a transnodal surgery, but post-operative IGF-1 levels remain elevated and growth hormone suppression after OGTT is inadequate. For the sake of residual tumor, they have performed a stereotactic radiotherapy with linear accelerator and medical therapy with lanreotide 120 milligram every 4 weeks and cabergoline 2 milligram weekly is initiated. 1 month later, patient presented with severe right hypochondrial pain, and they have shown the ultrasound here. What is the likely cause? You're seeing the gallbladder, and you can see 2 echogenic stones over here. So this is a case of cholelithiasis. So what is the likely cause of cholelithiasis here? It must be due to SRLs, the lanreotide that has been used in this case. What is the most common side effect of SRLs? It's going to be the gastrointestinal side effects, like nausea, vomiting, gastroparesis. Because of gastroparesis, they might get bloating sensation very commonly. So that's the most common side effect seen with almost every other SRL. And around 30 to 40% of the cases might develop an echogenic sludge. On top of that, they might develop gallstones as well, 30 to 40% of those cases, because of the inhibitory effect of the SRLs on the gallbladder. And because SRLs are also going to inhibit the output of certain hormones like insulin, you might expect hyperglycemia and worsening of glucose tolerance. This is quite common. In fact, the GI side effects and hyperglycemia is more common in patients who are using pasireotide than octreotide or lanreotide. And they might even develop a transient hypothyroxanemia, and they might even develop bradycardia. So these are transient effects, but yes, you need to note this as well. The patient has been followed up for the next 18 months, and after 18 months, finally, growth hormone and IGF-1 levels were controlled. However, she now complains of fatigue, weight gain, and cold intolerance, which are features of hypothyroidism. For the lab testing revealed TSH to be low and free T4 to be low as well, which means we are dealing with the central hypothyroid picture. What could be the reason for this central hypothyroid picture? It must be because of the pituitary radiation therapy. Usually by around 2 to 3 years mark, most of these patients tend to develop a kind of permanent hypopituitarism. That's what has happened in this case. So this is due to pituitary radiation therapy. What else should be done? And what else should be ruled out? So one of the important things to be ruled out is pan-hypopituitarism. In that, the most important is going to be ruling out ACTH deficiency. Because if ACTH is deficient, your cortisol is going to be deficient as well. If cortisol is deficient during the time of stress, there is a risk of death because patient will not be able to handle that stress. So that's why one of the most important things in this case of probable pan-hypopituitarism is to rule out ACTH deficiency. That completes the case of the week, episode 3. Thank you very much. See you next time.